Hi, I'm Tara, and today I'm going to talk about reality therapy, about specifically this book by William Glasser, but also just some of my readings and thoughts about reality therapy in general. The book was written in 1965. I figure we have to understand the context in terms of the psychiatric care at the time before we can even understand where he is coming from or what was on his mind. Interestingly, Thorazine had already been discovered to be effective in treatment of psychosis since 1950s and had been used for this purpose. Lithium was also discovered to be effective in bipolar mania, but it wouldn't be FDA approved until 1970. Imipramine was used in depression in the late 1950s, and Valium was being used for management of anxiety in the 60s. Insulin coma and lobotomies and a lot of the psychosurgery was left in the 50s. ECT, however, was commonly used and with anesthesia already in the 60s. Hospital stays were significantly longer, which the book does make a mention of. His conceptualization of a short stay is still multiple months, which is a striking difference from what we have right now. That being said, the deinstitutionalization movement had already started in the 50s with development of some of these aforementioned medications, and also was part of the Community Mental Health Act signed by JFK in 63. Perhaps most significantly, from the perspective of this author, the therapy scene at the time was predominantly still psychoanalytic based on Freud's teachings, which largely focused on past traumas and unconscious thoughts to analyze current behavior. And the treatment was very longitudinal and usually in private practice settings, which kind of limited it to the population that would be in the hospital or less socioeconomically advantaged. That being said, while he was working on this, the cognitive behavioral therapy perspective was also starting to pick up, where the behavioral approach was already being used for systematic desensitization related to specific phobias in the 60s, and the cognitive therapy approaches related to negative thought patterns and how they might be affecting your behavior were already being thought about in the 50s and the 60s. Combination of the cognitive and behavioral approaches really started to be utilized in the late 60s. Okay, so what is reality therapy? The first half of the book really talks about that, and then the second half is some cases. Also, from my research, this is one of Dr. Glasser's earlier works, and later he expands further and further into this, though I think this is pretty sufficient to understand what he's getting at. So there are three things that are at the foundation of his philosophy. They're responsibility, realism, and the distinction of right and wrong. As a side note, I thought it was very interesting that this was formulated while Ayn Rand was around and objectivism was very popular, because I thought there were some analogies in terms of the definition of responsibility and the emphasis that's put on reality. One thing we have to get straight is how he defines responsibility, because he will define people who are mentally ill as irresponsible. So it's very important to understand what exactly he means. I think it sounds pretty off-putting initially, so I was looking up the definition of irresponsible to see why I'm getting that connotation. The Cambridge Dictionary definition says not thinking enough or not worrying about the possible results of what you do. I guess that would be someone who doesn't have foresight, or perhaps is living too much in the moment and doesn't really think about the consequences of their actions. Still not very clear where he is going with that. In the book, he says responsibility is defined as the ability to fulfill one's needs and to do so in a way that does not deprive others of the ability to fulfill their needs. Basically, a responsible person is a person who can get their needs met. When defined as such, it's less bothersome for him to say that mental illness is a form of irresponsibility if irresponsibility means the person is unable to fulfill their needs. Because at the end of the day, that is part of the PEC criteria, right? For a physician's emergency hold, we say the person's gravely disabled. The implication there is that they cannot fulfill their needs in the outside world. Then to become responsible, he says the person would have to make choices that help them satisfy their needs in ways that are effective and respectful to others. In this book, he talks a lot about the need for love and human connection, and he really builds his whole theory of what therapy should be on that. The method starts with involvement of the therapist with the patient. He defines involvement as the patient knowing that you're someone who cares for them as a human being, and you will be there for them through this experience that they're having right now that's not pleasant. Here, he makes the assumption that everyone who is experiencing this is lacking sufficient involvement in their lives. And he really puts a lot of emphasis into what this involvement is supposed to look like, which is how he is able to say all of these people are lacking this very specific thing, because it's not just that there's some person who loves them. It's supposed to be someone who also is holding them to a high standard and is willing to provide them with reality orientation. Is what you're doing congruent with the person that you want to be? Now, he does say that the patients are the ones to make the judgment of morality on their behavior, but you also are supposed to bring in your own morality as the therapist and be willing to tell them what you think is right and wrong. He thinks they're missing this kind of sounding board, almost like a parental figure, honestly. So there's definitely a paternalistic element to this. And the idea is that the therapist is a template of a healthy connection for the patient. And by the time they're better, they're able to form that with other people around them by either connecting with the people in their lives in a more meaningful manner or meeting new people that they can become sufficiently involved with. I will say that's one of the things I like about his approach, where there is a clear goal and an end to his therapy, which should always be part of every therapy. What is the fundamental goal I have? Which probably most commonly can be just happiness. But then there should be a series of identifiable steps that you will take action on in a flexible but reasonable amount of time. And there should be a point where you graduate from therapy. This is one of the reasons I personally don't like the whole life coach industry. Everyone is supposed to be able to coach their own lives. Not at all times. You might need assistance, probably from someone who's gonna teach how to coach your life or like encourage you to do it, rather than someone who's gonna do it for you. Some of the things he does emphasize are don't focus on the past period and focus on the current behavior and what needs to be changed based on that. He also says throw out the unconscious, because the fact that it's unconscious means you can really not act on it in a significant manner. So he focuses on conscious current behaviors. Something of value in his approach is the emphasis on the connection between the therapist and the patient, and the fact that the therapist is expected to have some stake in the relationship. They're supposed to genuinely care for the patient rather than the overemphasis of transference and countertransference. He goes beyond the countertransference aspect of it and talks about a human-to-human connection where not every feeling you have towards the patient has to be analyzed from a countertransference angle. It could just be that you care for what they're telling you. He mentions that you might suffer with their suffering because you're experiencing it as a person with empathy. Obviously, the person who does the therapy will have to guard their own health as well. But I do think there is value in normalizing the fact that, yeah, sometimes you do feel stuff. And that's one of the things actually that comes up a lot when you tell people you're going into psychiatry residency. Well, don't you get sad? Don't you, take it home? And I think you should definitely look inward and see if that is something you can be comfortable with and what your level of taking it home is. But I do think it would be disturbing if someone just did not feel at all saddened by the things they hear. Another thing that he does mention, when you're working with someone, you want to figure out what their highest potential is and help them achieve there. So it might not be very clear to them why they're not happy because their life is okay, but they might not be necessarily reaching their highest potential, which I think is a very common thing, actually. There was another book that I enjoyed very much, The Defining Decade by Meg Jay. And she talks about how being underemployed when you're straight out of college can be more depressing than being unemployed. And I think about that all the time whenever the topic of not fulfilling your potential comes up. So a big period of initial meeting with someone is them talking about their current life and their interests, and you also chime in to make a human connection. And at this time, he believes it's significant for them to not bear what they might perceive as past mistakes or their traumas to you. He does say eventually when you do have some amount of rapport with the patient, a level of involvement, he would say, it's more okay for them to mention whatever they want to mention about the past, but you still, as the person who does the therapy, not dwell on those things and you focus on the current situation. You listen for their plans and their goals, and you want the patient to come up with a plan in terms of whatever they came to you for, like what would be your plan to fix this? And then you are the person who's supposed to kind of help them integrate what they're doing right now versus where they want to be and highlight the disconnects and give suggestions as to how they can fix it. He does repeatedly mention that you want to have high expectations of the patient, but you want to have the goals be achievable and small steps. It's very singularly focused on the patient. So even if they come to you with an interpersonal conflict, if you just have the one patient and they feel like they've been wronged by this and that, even if that may be the case, you just focus on, well, what can you do about this? Which is a good approach and realistic because we really can't a lot of times control other people or the environment. But for him, it's especially significant because he wants you to take a lot of responsibility. And the idea of the high expectation and the responsibility with an achievable goal is that if you are sufficiently involved with the patient, you're someone that they want to make proud because you are someone that believes in their success and encourages it and expects it so that they will want to do better, live up to your perception of who their best self may be. At the end of the day, a lot of the book keeps coming back to the fact that the lack of involvement in someone's life is the most profound thing that they're missing and is the reason for any mental illness, in quotes, for him because he doesn't believe in mental illness. It's an interesting thought. It's likely really simplistic when we think about the range of mental illness that we now have a better conception of. However, it did make me think about the book Into the Wild and the conclusion of that being happiness is only real when it's shared. He would, I think, very much agree with that. Now, in terms of his perspective on mental illness, like I said, he believes that there's no such thing as mental illness and it's all irresponsibility. So an inability to fulfill your needs, which really sounds like an outcome or symptom of something rather than the reason. As in, if your problem is that you can't fulfill your needs, how can that also be the reason that you can't fulfill your needs? So it kind of seems circular to me. He's not necessarily part of the anti-psychiatry movement because I don't think he's thinking politically about this the way a lot of the anti-psychiatry movement people are. And he seems to still see a lot of value in treatment in a controlled setting. His reason for denying that there is such a thing as mental illness seems to be partly motivated by the fact that he doesn't like to label the patients and feels that's unproductive, which honestly is kind of a valid case. Is it possible to over-identify with your diagnosis to the point where it maybe takes up more of your life than it would have to? Especially if they're psychiatric, because it concerns the mind, and the mind is so intertwined to, who you are in your essence, that there is some value in a discussion. This is a communication device. This is like a summary of the symptoms you're experiencing right now. It's worth exploring if there's a benefit to you minimizing its significance in your day-to-day life. Second reason he seems to think mental illness is not a thing is because diagnosis, he says, doesn't matter because it doesn't affect the treatment, which has really thrown me off. Some of the medications that were around are like Thorazine and lithium, which we still use, and they work. I think he approaches it from a therapy angle, and his therapy is one size fits all for the most part. But I'm still surprised that he thinks they're all the same. Perhaps this is coming from a place where we have a lot more clear definitions in the DSM in terms of what every illness is. Maybe I'm speaking from that privileged position, and now that things have been pointed out to me that they're very obvious, and maybe they wouldn't have been if they weren't so significantly pointed out. I like the idea of having personal responsibility for your own happiness and emphasizing an internal locus of control. I also like the fact that he doesn't shy away from the concept of an objective good. People are free to make their own value judgments, but at the end of the day, what's objectively good can be identified by the fact that it promotes their survival and happiness, versus something that doesn't. One is actually the importance of therapy for all psychiatric disorders. We almost have it flipped where he had a blind spot for the biological basis, and now we can sometimes have a blind spot for the philosophical basis. And specifically, I was thinking about delusions, which are notoriously difficult to treat because they're a disorder of thought content, and how a lot of these patients can access pharmacological treatment a lot easier now than therapy, whereas maybe they would significantly benefit from that, and it's being overlooked to a degree. There's a huge part of this where either you literally couldn't have done anything differently and you just have a chronic illness, or it could be something like they're doing what everyone else around them was doing at the time, which could be like smoking weed or even alcohol, and it affected them differently than everyone else, and now they're dealing with the consequences of that. Now, starting from that point, you can empower and encourage people to take control, even in situations like a personality disorder where the treatment is not necessarily pharmacological. It's a big oversight to define it as an irresponsibility. Even if you wanted to take his approach, there should be a distinction between focusing on the precursors and the origins of the illness heavily to the point of dwelling on it, which he doesn't want to do, versus discounting the fact that it has happened. Lastly, I'll leave you with this excerpt by Ayn Rand, which I find compelling. A lot of the merits of the book come from the fact that he acknowledges reality. And she says, "Man does not create reality and can achieve his values only by making his decisions consonant with the facts of reality." So that was my thoughts on reality therapy. I hope you enjoyed it. Thank you for watching. Bye.